Latin America. Nature. Its land. Its people. Its culture. Science. Argentina, the 8th largest country in the world. Awarded with universities of more than 400 years of history. Where great personalities of sciences recognized around the world stand out. Cordoba. Historical, cultural, industrial. Epicenter of the first Argentine university and the second school of medicine in the country. Cordoba is a province of intellectual progress, productive and technological. An icon in South America, where one finds the highly prestigious institutions of the region. Hospital Privado, more than half a century in the service of the community. Hospital Privado, ethics, knowledge, innovation. Cordoba, Argentina, Latin America.
Good morning, Alejandro.
Good morning, Chad. Thank you very much for this invitation. It's a pleasure and an honor for us, all our team in Cordoba, to be involved in pics as a second year in a row. We are really very happy with this opportunity that you give to us. So let me first of all introduce the people that we are working in Cordoba today. This is a very cold day in Cordoba. Let's introduce to Dr. Leon Salzano, is our cardiac anesthetist. Also, Dr. Analia Priotto, cardiac anesthetist. Dr. Alejandro Contreras, our echocardiographer. To my right side, Dr. Adolfo Ferrero. He used to be our fellow, now is our junior staff. And Dr. Lucrece de Anquin, she's starting her fellowship program. Also, Pablo Pogonza has made a great job putting all the necessary stuff together here, our nurse, and our two techs, Sabrina Inama and Osvaldo Narciso. All of them are very happy to be part of this project. Let me just go over the slides. Dr. Adolfo Ferrero will present the first case, and we would like to have a discussion, and then we will move forward from there, Cian. Next.
Well, this is the first case, the history of this patient. She is a 13-year-old girl with fatigue and mild dyspnea on exertion, found to have a murmur recently. His physical findings, his weight is 41 kilograms, BP 1960, over 59, have a mild 2 out of 6 systolic ejection murmur at the upper left external border, fixed splitting on the second heart sound with mildly increased pulmonary component. A large family history with his mother with ASD, 25-year-old brother with ASD, 22-year-old sister with ASD, and 8-year-old sister with a multiple ASD, all treated with surgery.
Next one.
Next.
Next.
Pertinent test, EKG, sinus rhythm, heart rate 90 per minute, PR interval 0.27 second, QRS axis, plus 10, first degree AV block, and incomplete right bundle branch block. Chest rate, mild cardiac enlargement, increased pulmonary vascular markings. Echo, transesophageal, and multiple ostium secundus type ASDs, large of them, defect measuring approximately 15 millimeters, and smaller defect measuring 4 millimeters, with 4.5 millimeters separation each other, with right atria and right ventricle enlargement, and normal PA pressure.
Next one.
And the next, the intended intervention is percutaneous multiple ASD closer using the PFN Nitoclut ASDR reverse device.
Next one. So you see there, Siad, the EKG of this patient that has a clear first degree AV block with 240 milliseconds PR interval, and also you have the on the right hand panel the chest X-ray with mild cardiac enlargement and increased pulmonary vascular markings. Next one. This is a static pictures of her TEs, her initial TE, showing both ASDs with color, both of them, but we have plenty of pictures that we would like to show in a few seconds. Next one. So this patient has a very interesting family history. And also I just add there the EKG of the mother that also has a first degree AV block, and she had surgically corrected ASD, and the 80-year-old sister's EKG that also was surgically corrected her ASD and has a PR interval of 240 also. So this mother has had 6 children, and 4 of them have ASDs, and she has first degree AV block, and also 2 of her children has first degree AV block. Next one. So we moved forward and we did hemodynamics in this patient. The SVC SAT was 70%, the PA SAT was 89%. There's a significant increase in the saturation. The PA pressure, the mean is 17, and you see there the calculation, the QPQS is 2.7 to 1 and has normal pulmonary vascular resistance. So, yeah, this is the case, and we will show now some echo pictures. But if you have any comment, because this patient fits into the syndrome called the familial ASD with AV disturbance, that those kind of disturbance are at AV node level with first degree AV block and with progression of those with time. They are located in the Tillman gene homologous to the human, that is a transcription human cardiac gene called NKX 2.5 mutation. So it would be very interesting the opinion of the panel, you, John, Carlos, or Tom, or the rest of the audience, how to treat or how to plan a procedure in this type of patient that has a large PR interval and multiple ASDs.
Yeah, that's great, Alejandro. This is a good case. So you clearly this is a familial case of ASD. Obviously, when you want to do differential diagnosis here, obviously Holt-Oram syndrome comes to the picture, but I assume this patient and his family have no skeletal deformity.
No.
Then when you discuss the conduction system, that's when you have to think of what we call Tillman syndrome, which is the genetic mutation, the NKX 2.5. And the question, of course, here, what is best, surgery versus device closure? And Alejandro and I discussed this case, and I, from my personal experience, recommended, of course, device closure, because with surgery, there's no question increased risk of heart block because the conduction system is right there. Let me ask now my moderators and the panelists, what would they do? Carlos, what would you do?
We also discussed this case, and I would go for transcatheter closure. I think we don't know the risk. We don't have that many cases. The risk of progression to complete heart block probably is the same, no matter what you do, either surgically, theoretically it's higher, but we don't know, or for device. We can see two holes, and I think you can get both holes with a single device, and I think this is good, would decrease the likelihood of getting heart block here.
Yeah.
Any panelist would like to make a comment? Warkan, push on the...
Good morning, Alejandro. It's Warkan from Bangkok.
Oh,
Nice
hi,
to see
Warkan.
you again.
How you
So
doing?
may I ask you if you have the 3D imaging of this, echo, because I think there are two holes actually, but if I can appreciate the 3D reconstruction, would be much more appreciated.
Yes.
Alejandro, do you have 3D?
Yeah. No. Unfortunately, we don't have 3D availability here. So this is the way that we do it. But of course, Warham, I think that 3D would add a lot here to this case. Regarding the AV blocks here, if you see the literature, there is just scanty of information, and there is just one very interesting paper from Haifa, from Israel, with 4 or 5 families. Among them, they have 28 affected members, and they went for surgical closure, 10 of them, and they went for ASD closure with a device in 12 of those. And
yeah.
actually,
Alejandro,
yeah.
Can you show the pictures bigger, the TE, and
Yeah.
you could go over the case? And while you do that, I would like to hear the audience opinion as a show of hands. Who would send this patient to surgery? So nobody would send this patient
Echo
to
bigger,
surgery.
please.
Everybody agrees with you that she
We have
should
no
have a
surgeons
catheter.
here, guys. Come on.
Yeah.
Everybody device? Wow. So there's one guy there, surgery.
Surgery. Why would you send this patient to surgery? Please come and say why.
Okay. Alejandro, go ahead. Why don't you start working on the case while you are showing us the echo?
Yes, please. So
Go ahead.
So one discussion is solved. So we will go for device closure of this defect. And second is how to approach multiple ASDs here. If you there has been a lot of debate regarding stage approach versus simultaneous device closure. I'm not meaning for this case that they are close each other, and I assume we will be able to close both holes with just one device, smashing the second hole. But I would like to know your current opinion about if stage approach like Horst published last year versus simultaneous approach is better.
Alejandro, we have a question from the floor. Dr. Amin, go ahead.
Please.
Alejandro, clearly as Warkan stated, this patient has 2 atrial septal defects, and the one that is away from the aorta is a smaller defect. So in order to relatively decrease the chances of AV block in such a patient, my suggestion would be to go through the smaller defect and put a non-self-centering device, so it has less radial force on the atrial septum. So, and if you put a non-self-centering device, it should cover this bigger hole with it.
Yeah.
Alejandro, John Cheatham, along the same lines as Zahid, one of the limitations of the TE echo that you have right now, you've really not ruled out that there's a lower defect lower than where you see, because you can't see the inferior part of the septum, the IVC part of the septum, and you could have also a small defect which goes then back to what Zahid just said is a non-self-centering, and the middle defect would probably be the best, and you cover everything.
Yeah. Actually, John, actually, we scanned the patient this morning just a few minutes ago, and actually our echocardiographer initially saw 2 defects, and then he thinks that there is a very small 1 millimeter additional defect in that specific region is shown there, where you mentioned, yeah. So this is a large ASD, the initial one, and there are at least 1, maybe 2 smaller ones. We know perfectly that 3D echo would help here a lot, but unfortunately we don't have. But actually, John, I read your paper about progression of AV block with an unplugged device in a 6-year-old patient. So what do you have to say regarding this case?
Well, that particular patient didn't have this family history, number one. That also patient is someone that had left SVC to a dilated coronary sinus that shortens interatrial septal length and pushes down on the coronary sinus, so had some anatomic reasons. But what you've shown so far, personally, I would try to go through the middle defect and put a non-self-centering device.
Alejandro, we're going to need to proceed with you. Please start while working. Shaq has a question while you are working. Shaq, go ahead.
Okay,
keep working while you're talking.
Perfect. So
Alejandro, you carry on. Good morning to all of you. I was actually going to say the opposite of what Zahid and John have said, and that is that I would close the larger defect and not worry about the smaller ones. Because if you plan to put 2 devices in, you're more likely to progress with a heart block. I would stick with a single device and single self-centering device through the large defect.
I would agree with you, Shaq.
Okay.
Me too.
So,
we agree with the single device, just not the device.
Okay.
Go ahead, Alejandro.
Great.
We're listening.
Great. So
I think I would make this simple, like going through the larger device. Go ahead, Alejandro, while you work.
So Carlos, we just made our decision. We moved forward and we just balloon size this defect, and we try to inflate the balloon a little bit in order to see if we could smash the second hole. Initially, the measurement we are using here, the PTS NUMED balloon, and the measurement for echo initially was 18 to 19, and then with balloon it increased to 23, 24, and the balloon was 24.55. So we are dealing with a larger defect that is approximately between 23 and 24.5, and with the balloon. Ale, could you show the balloon? Once we inflate the balloon in the septum very gently, we could not see the other hole. So I don't know if we couldn't see the hole because they are lower down, but there was no residual shunt. So what we have...
Can we see the pictures,
yeah,
the echo pictures,
please,
Alejandro, with the balloon up?
The echo picture, the other one. Echo picture, Carlos, there. You can see it. Next one.
So what about a color flow in the inferior portion of the septum?
Next one. There was none, Carlos. No residual shunt. I don't know if that was recorded.
Perfect.
So,
Ron, you have a question?
One quick question. I think you have to be very careful when you have a deficient retroauric rim not to smash the other defect by oversizing the device. I had a very similar case recently, and you have no retroauric rim. You try to occlude the other defect, and then you oversize the device, and that can potentially cause problems. So don't get bucked into trying to oversize just to cover a smaller defect and then creating problem at the aorta.
Yeah, that's true. That's what we have planned, just gentle inflation, and with that kind of pressure, the second defect smash or disappear. So, and it was a floppy septum. So we think that one device will cover both. But if we have 2 distant defects, we actually will go for the larger one, and we will use or advocate the stage approach. Most of them, according to horse paper, decrease in size during a short period of time. So, and they are not clinically relevant. So, in this occasion, we we don't have plenty of devices here. We have the devices that are set for each patient. So we don't have stock, meaning that we can use the device that we have chosen in advance. So we will try to implant in this patient a NitroCloud ASDR device. Maybe many of you know the device. It's a double disc device made from a single nitinol wire mesh, and has two discs that are equal in size. I don't know if you see it well there. Are equal in size, and it has the locking wire that cross entirely the device as a subjection mechanism, meaning that a locking wire that you see here has 0.004 distally and 0.014 approximately, crosses entirely the device that is attached here at the right side of the disc by the pusher that have 4 subjection wires there, and it works as a snare. So this is the simple release mechanism, and has another feature that is that the distal left atrial disc opens in a reverse way. So if you see here how it opens in a reverse way. First the locking wire, and then the left atrial disc in a reverse way, and then this is the shape that adopts in the left atrium that Carlos Pedro likes to call Chinese hat, and then the rest of the device is open, and finally this is the final position of the device. So with all this, this device has 12 commercially available sizes from 8 millimeters in weight to 30 millimeters. So it's for small to moderate size ASDs. It's not good, or it's not useful for very large ASDs. And it goes through an 8 to 14 French sheath according to the size that you choose. And
how big a device you're using, Alejandro?
So, Carlos,
you're going to use?
Perfect. So we measure approximately 23.5, 24.55. So we have chosen a 24 millimeters device. That is the one that we have here in our hands. So now
Z, whilst Alejandro is demonstrating this, quick question to the panel as well, because balloon sizing here is really going to result in oversizing. This is a very thick-looking septum. It's not a floppy septum, so you don't really need to oversize. And here, with balloon sizing, you could see the waist. We didn't see clearly what happened on TOE, moving picture, but
keep going, Alejandro. Keep working.
Yeah, Alejandro, you carry on. So how many would have balloon sized this defect? That's an important question.
I wouldn't.
Right, more on the opposite. How many would not balloon size this defect? There you are. So we'd finish up probably using a 20 device, or maybe 22 at most, but it would be undersized, certainly not oversized like this.
I think, Shaq, once he deploys the device, looking at the waist, if the waist is pinched, then I would agree with you it is oversized and perhaps you should not release it. But if the waist is relaxed and not much oversizing, I think a 24 millimeter device probably is appropriate.
Yeah, but it's more having done balloon sizing, yes, but I would, looking at that thick septum, I would not have balloon sized and gone on the TOE.
Okay.
But see in chat,
Dr. Xenopoulos?
Yes, I think that balloon sizing of this now is an absolute technique,
Alejandro, carry on.
Yeah, because most of the time you oversize the defect, as Zach says, and we've been using the echo diameter of the defect, and once the septum is of normal thickness, we use a 4 millimeter balloon as the occluder larger. So in this case, I think I agree with SAC 22.
Okay.
I think there is no reason to balloon that effect now.
Thank you. Let Alejandro carry on. We'll have one of the questions until he deploys the device. Go ahead.
Okay, great. So we are just in this step. The 14 French coke sheath is in the left atrium, and the device has been advanced until the tip of the sheath. You see there the locking wire that is going out of the sheath. Now we move from the vein to the left atrium body. So now I would like you to pay attention how the left atrial disc opens in a reverse configuration way. Look. There. It opens. Yeah. So there you have the locking wire distal and the left atrial disc open. And this is the shape that Carlos like to call the Chinese hat. And you see two platinum markers distally for radiological guidance of this device. So now it's coming straight. You see there in the echo? Can you see the echo? And the device is coming in a good position. And now we will try to open the right atrial disc. It's coming nicely there. I like the way it is coming. So I will stop there, and I will try to undo the right atrial part of this. And then very, 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 very gently, you just push the right atrial disc, and you feel like a click sensation, see it in your hands, in order to make the right disc concave to grab the septum.
Alejandro,
so now we will,
please,
Sorry?
It does look good, because if you oversize this device, it becomes very, very, very bulky.
Yeah.
You cannot get away with real oversizing with this device. Can you make a comment on that?
Yeah, that's totally true, Carlos. The right atrial disc is not forming properly if you oversize the device significantly. In this case, we have a very flat device, and it formed properly during the first attempt of closure. We are happy with that position, and also it's very important, like Carlos mentioned, to feel that click sensation from the right atrial disc, because it makes the right atrial disc concave and it approximates both discs. And look at the echo. The central portion of the device is not made from a nitinol. It's just a polyester membrane, and you see there that it's not straight, meaning that is an indirect sign that the device is an appropriate size. Because if it was very, very straight, meaning that the device is just undersized. Put some color there, and you see that due to is nitinol, just the border of the left atrial disc and not just membrane. Take a look that there is some leaking there, and this is 100% of cases when you put this device initially when the patient is heparinized. You can see some flow centrally through the polyester membrane that disappear during the first 24-48 hours. And you see there that Alejandro Contreras, our echocardiographer, cannot see the other accessory ASD. Alejandro, you see some residual shunt there? No.
Alejandro?
Yeah. Yes, Jacques, please.
Yeah. One thing you could do, or ask your echo person to do, is measure the waste on the TOE and also on fluoro, and that will give you some indication of the compression, if there is any, or oversizing.
Bárbaro. Okay, Jacques, we can do it. Alejandro, medí la waste, nosotros pusimos un 24, el waste del medio más o menos. It's not going to be easy to measure it on angio, Jack, but yes, on echo. Yes.
Alejandro, this is Tom Jones. Good morning.
Hi, Tom. How are you doing?
Good, very good. Quick question. I'm watching the left atrial disc very close to the mitral valve leaflet, the anterior leaflet. Are you confident that you're off of it or you're near contact? I mean, I think the device otherwise looks great. The question that had come up initially about perhaps of one device size smaller, 22 rather than 24.
Yeah.
But I wanted to ask you about this mitral valve issue.
Yeah. Actually, we put attention to that. There is no incompetence of the mitral valve, but we are very proximate there. We are close there. But I think that it's not justification for changing the device. I think that the device sits well there and close all the ASDs, and it's a flexible device and looks okay. The other thing that you, I don't know if somebody asked already, but the rhythm didn't change. So the patient has a normal sinus rhythm with first degree AB block. I don't know if they can show you the monitor where the EKG is shown, please. So it has a persistent first degree AB block. The next question would be for Sia, Carlos, or Tom, or John. How are you going to talk to the family after this successful closure? I think regarding the possibility in the future to develop complete hard lock.
Well, we don't really know what's going to happen, right? It's a matter of following those patients, mirroring, Holter, all those things, maybe more often than we do for other patients, and see that, late heart block can still happen in these patients.
Yeah. Yes, you are right, Carlos.
Alejandro, why don't you go ahead and release the device? I would not keep cables like this that long in the heart, because they form a clot.
Let's. So we just.
While you do that, is Zahid there? Zahid?
Yeah, let him show us how to release.
So here we just took off the security seal, like is in my hand here, and then you just grab the locking wire, and then once you are there, you just approximate the sheath a little bit to the device there, and then you just bring the locking wire out.
Can we see fluoro as well, just to see if the device will adjust itself or anything? Can we see fluoro?
Fluoro bigger, please. Fluoroscopy bigger.
Is release here. So you just bring everything down. Please show the place. Perfect. So we just brought the locking wire, and the device was released. And you see that there was not a lot of movement from the initial position of the device. If you took a close look of the platinum markers that the left atrial disc has there, they have not moved at all. So it was very stable in position and did not move after releasing the device. So let's show echo. The echo closed the ASD completely, and also the angio has a good position there, and also the EKG that has a first degree AB block, exactly the same than before.
Let me ask, Zahid is here. Zahid, you've always made a point on the position of the device with regards to the aorta. If there's a sort of recess between the aorta, a space behind the aorta and the device, then the likelihood of getting an erosion is less, maybe. What do you think about, the appearance in this case? It seems that there is some space between the device and the aorta.
So if he enlarges this short axis view...
can we see the echo bigger?
Yeah.
Alejandro, can we see the echo bigger?
Echo bigger, please.
Maybe if you come up with the probe a little bit and short axis to the aorta, there you go.
Zero.
So if you see now that the aorta is completely separate structure from the atria. So you see the atrial wall. Can you go back to pull your TE probe back a little bit? So give me some part of the aorta.
Yeah,
Alejandro.
Front axis, Alejandro. Maybe
aorta,
30,
subilo,
60.
no, aorta.
Or pull
0
back
grado
your-
y aorta, yes. There.
There.
There? Okay, I do
So,
more.
Can you show us
No,
the whole
30
aorta?
degrees.
Menos. Vale, aorta.
Okay,
No,
and anyway,
here,
if you look at this picture, you see how the aorta is separated from the device with every systole.
Sí.
See how the device moves away and there is a space. That's the transverse sinus, surgical, but that's what the surgeon calls the transverse sinus. So the free wall of the atrium is where you see the free wall of the atrium keeps pounding on the edge of the device, on the left side, when he shows you the short axis. So this device, I think, should be okay, but if that area was tented, then absolutely positively it increases the risk of erosion.
So in the end, you are happy with this position?
I think this device should be okay. Yeah.
Okay.
Any question from the panelists on this case? Dr. Wang.
Yeah. As I know that the right disc is the same size with left disc, right? Because this device implanted is a little bit oversized than the unplus occluder. So one thing I worry about is the right disc may touch the septal leaflet of the RV. So is there a possibility that this device may increase the risk of AB block?
Alejandro, did you understand the question?
Yeah, if I understand correctly, the question is if this large device is going to increase the risk of AB block. We discussed that before choosing the size, but we want to make sure that everything was covered as a one-stop shopping. But if this device could have shown when you implanted a second-degree AB block with type 1, type 2, we would remove the device immediately without releasing it and changing for a smaller one. So that was our initial strategy. In the long run, nobody knows. And this patient have just in spite of surgery or device closure, almost 34 to 54% chances of complete heart block in the future. So it's a very, very high percentage of patients that even if you leave the ASD without closure due to this genetic disease. So this is a difficult call to answer.
Great. This is a great case, Alejandro. Thank you for this nice transmission. And there's no questions. We're going to leave you and go to Riyadh, Saudi Arabia with Dr. Jofan to see his first case. Alejandro, thank you, and we'll see you for the next case.
Congrats,
thank
hermano.
Great, thank you.
Okay, let's go.
Qué nervio. Perfecto. Vamos. Para que le hagan protamina.